Hey, good evening, everyone. Welcome to another session of Virtual Global Spine Conference. Really excited to have a good friend of mine, Dr. Stanley Hoang here. He is a complex deformity and minimally invasive spine surgeon from the LSU at Shreveport. And this looks like it's going to be a real fascinating talk that he's giving us tonight on awake prone lateral interbody fusion. And then he'll kind of divert and talk to us about AI applications in spine surgery. So welcome, Stanley. It's great to see you again and really looking forward to your talk tonight.
Yeah, thank you, Mike, for the invitation. Thank you, everyone, for attending. Just a side note, this is a great platform. I was telling Mike that I was done from my auto board a few years ago, and actually watched all the videos up to that point, and was very instructive, and I learned a lot from everyone watching those videos. So great to be a part of this. So today I'm going to be talking about a couple of things. My disclosures that I consult from Medtronic. I teach pro courses for them. So I'll be talking about three different kind of topics. The first part is about doing a wake prone lateral. I adopted doing lateral approaches a few years ago, early in my practice, and then after that I switched to doing prone lateral. And then seeing we got our workflow down pretty well, we consider trying to do that awake because that saves a lot of time and also allow patients different options, especially if they're sick. And the second part of my talk is about using AI to analyze video of surgeries, in this case, lumbar pedicle screw placement, and see if you can use different parameters to quantify, people's performance and the way they do the surgery. And the last part is about looking at a different way to use AI to analyze MRI, looking especially at vertebral bone quality, which is a marker for bone health. So the first part I'll be talking about is the awake prone lateral. Um, and I guess there are three different parts to this talk. The first part is talking about spinal anesthesia, because this is important to do instead of doing general anesthesia. The second part is about my prone lateral workflow and using navigation to do that. So I will start with my case presentation. So this is a 77-year-old male, history of mechanical back pain and collocation. It works with ambulation. He's done all the safety management that we can think of, PT, ESI, pain management for up to a year. Did not get any relief from that. On exam, he has a right foot drop, and this is from his hip surgery 2 years ago. That happened right after the hip surgery. So I think there was some injury from that caused the foot drop, and not so much from the lumbar stenosis. In terms of his past medical history, he has a history of aortic valve replacement. He has a pacemaker as well. He has severe LAD stenosis, so a very sick guy in terms of cardiac history. Here's the MRI lumbar spine. You can see that he has severe stenosis L3, L4, central disc here, pretty tight. On the CT scan, you can see here, it's a very collapsed disc space. And then you can see the central disc calcification in the center right here. So, there are different options to for treatment. Obviously, try to do consultative management first, right? To do PT, SI. He doesn't know that, did not get any relief. So the next thing would be to consider surgical options. And in terms of surgery, as you can see here, there are many different approaches you can do. You can do a T-lift, you can do an A-lift. Even although A-lift at this level typically not done very commonly. You can do a two-stage approaches when you do lateral approach, putting a cage from the lateral side, and then do decompression and screw from the back. The other option would be to do single position where you place the cage in the lateral position and then turn them prone and do the screw and decompression. And then lastly, could be to do the same thing but in the prone position. And we picked the prone position lateral approach for this case in particular. And the thing that we did with this case, instead of doing general anesthesia, I wanted to do a wake with spinal anesthesia. And the reason that we picked doing a wake case in this case, because this patient has very severe cardiac history. He has aortic valve stenosis. He has pacemaker, severe LAD stenosis. So we would think that doing a wake would be the best thing for him in terms of his risk factor. And then the other thing is that with our surgery, the lateral approach allows you to correct the the disk space collapse. So by doing that, you can place a large interbody cache, and this will help with indirect decompression. And at the same time, you can also do a posterior decompression and fusion as well, because it has very severe stenosis from the calcified disc and the ligament flavum hypertrophy. In terms of the different approaches for awake spine surgery, there are three main approaches. You can do local, epidural, and spinal. Local epidural, they kind of a bit inconsistent, so you have to, to put out the case, have to infuse more medication to keep the patient keep the patient stable. With the spinal, typically just a one-time administration right before surgery, and it can last for up to 3 hours, depending on the rope you use. In this case, we picked bupivacaine because it gives you a very consistent 3-hour time window where the patient, completely still for you to do surgery. So you can see that for the spinal, you have to do a lumbar puncture basically. So you do a spinal tap, to be around L3, L4, and you inject bupivacaine into that into the intrathecal space. And this will allow the patient to be pretty much paralyzed for 3 hours for the surgery. There are a few contraindications for spinal anesthesia. The most common one is aortic stenosis. And the reason for that is because when you do a spinal anesthesia, you basically block the sympathetic nervous system. So when that happens, patient can have hypotension. So, and then in someone who has aortic stenosis, the hypotension can be very serious. It can cause ischemia. So you don't want to have someone with aortic stenosis undergo spinal anesthesia. This patient we have actually had very severe aortic stenosis, so we actually treated him with, they did a valve replacement on him before we did this awake surgery. The other contraindications are more obvious. This includes hypovolemia, elevated ICP, and coagulopathy. So the way that we did the spinal anesthesia on this patient is that we got him, we in the holding area, we got him to the OR. This is anesthesia resident here, and he was, he did a lumbar a spinal tap, L3, L4. He injected bupivacaine intrathecally at this level, and after that, you want to confirm that he has a blockage in terms of sensory blockage before you turn him prone. So we did the spinal anesthesia. We make sure that he has complete anesthesia from the waist down, and then we turn him prone on the Jackson table. You can see here. We just use this prone view that that you get that we use for spine surgery. And notice here that this patient has a very frozen shoulder on the left side. So because of the fact that he was awake, we're able to get his shoulder position the way that he wanted, and not otherwise, we have lifted this up way higher, and this will cause him to be very uncomfortable after surgery. So by having him awake, we're able to get the shoulder position in the correct position for him. So the main disadvantage of spinal anesthesia is that you only have 3 hours. So you have to get everything done within 3 hours, because after that, that will wear off, and you don't have to stop your surgery. So you need to optimize your surgery in such a way that skin to skin under 3 hours. The other issue with spinal is that when you do spinal, you lose all motor and SSCP potential. So you cannot monitor MEP, SSCP during the case. However, one thing that you should keep in mind is that even though you don't have MEP or SSCP, EMG is still reliable. So this is important because it allows you to, when you do lateral approach, I typically monitor my lumbar plexus. So I use trigger EMG as I do transpsoas approach. So so in this case, even though you do spinal, the EMG is still reliable, for the transpsoas approach. And then the other thing is that, and I use navigation for this case. So when patient is under spinal, they can still move, upper body. So that can really that can jeopardize your navigation if you're not careful. So in this case, I use what they call a bone fiducial. I'll show that in more details later. But this is one way that I use in all my cases to make sure that my navigation stays correct during the whole case. So just quickly talking about MEP during spinal. So you can see here, this is a diagram showing that for the MEP, typically we stimulate the motor cortex. The signal goes down the spinal cord and it crosses into the motor neurons on the other side. the spinal anesthesia will block that pathway. That way, patient has no feeling, no motor or sensory function, from mid thoracic down to the legs. Um, and then, however, the EMG still works because the way EMG works is that it works on the peripheral nerve. So, so let's say you want to steam your pentacle screw, or you want to steam your probe as you go trans-psoas. Because EMG still works, it's still reliable when you go trans-psoas. So in this case here, you can see the train of thought here that we have. This is the real patient that we did, the tracing. So the T is the trigger EMG, um, um, and you can see that the train of thought is still intact. So it signals that you can still monitor the nerve root, doing the operation. The other thing that I always do for all my cases for navigation is I use this striker screw. So all the new surgeons here know this. We use this screw for our cranial cases to plate the bone flap. So what I do is I just use on these screws here. I typically put into the spinous process around where the area where I'm working. And so when I have this in the spinous process, I get my O-arm spin. So my O-arm spin will also consist of this screw into the bony anatomy, so that I can check and verify that my accuracy, my navigation is correct throughout the case. So you can see here on this diagram here, this is the navigated Midas screw. I'm sorry, navigated Midas drill that we use. So I put the tip of the drill on top of the screw here, and you can see on the navigation that it matches very well to the anatomy. So I think this is much more reliable for me because I can actually visualize the metallic screw, and then I can check that it's consistent for the case. You can use bony landmark too, but I feel this is much more reliable. I can see better in terms of confirming navigation accuracy. So the last part is about talking about a little bit about single position prone lateral. So this is basically used to be two operations, right? So we do the lateral first. We have patient in the lateral position. We put the cage in. We turn them prone to do the screws. Now with single position, you can do both at the same time. So you see on this diagram here that we can do the see perk screw, for example, from the back, and then the cage from the side here. And the advantage of the prone lateral is that it allows you a very efficient workflow. So no need to turn the patient from lateral to prone. You can do everything in the prone position. This is very important because with spinal anesthesia, you have about 3 hours. So you need to get things done under 3 hours. Otherwise, it will not be feasible. So if you were to do this in two stage, it's not hard to do it under 3 hours. But with the prone lateral approach, I think it can be done comfortably under 3 hours. Here, just a picture showing my patient here. You spread the back and the side at the same time, and and then you can work at the same time. The advantage of prone lateral is that when you lie prone, you have improved lordosis, and it allows you to correct deformity in the sagittal plane much more easy than in the lateral position. In addition, the abdominal content will because gravity, it will migrate away from the working field anteriorly. So that will allow, in theory, less risk to the peritoneal content. And the other thing that also important is that the lumbar plexus, located within the psoas, because when you lie prone, it actually migrates away more posteriorly. So that also allows less risk to the lumbar plexus. So I think those are two main advantages of the prone lateral approaches, besides the time saving and the efficiency that it allows you to do these cases. So for my OR setup for this case in particular, we have the anesthesiologist at the head with the patient here. I did this case with my chief resident, PGY7. So he was on the right side. He did the posterior part mostly, and then I was on the left side, sitting down doing the lateral part. My navigation equipment is at the back, at the feet of the patient, and the scope is on my side. And as I mentioned, we use navigation for this case because I think it's just a more efficient workflow. And one thing I learned is that with navigation, you can put screw from both. You can put screw on both sides, standing on one side. So in this case, my resident will be able to put screw in both left and right screw standing on the right side. and so I did not have to go on my side to do the screw. So I was focused on my side here, and he was staying on this side to do the screws. I did my cage on the left side. The key step that we have is that the first part, the first thing we do is we place the reference frame to the PSIS, and then I place my bony fiducial in the spinous process, which made a small opening at L3 or 4, put in my bony fiducial. I then put my O-arm in and get a spin. And then after that, we work simultaneously doing back the lateral and posterior at the same time. So this is the timeline of the operation here. So total, it took us about over 2 hours or so for this case, doing cage at L3, 4, and also screws bilaterally and decompression from the back. And you can see that, so on this diagram here, this is the timeline of the operation. You can see that we do spine anesthesia around 0 minute, and then we go prone around 5 minutes. We got an O-arm spin about half an hour after that. We made our posterior incision about 40 minutes later, lateral incision at the same time. Around 50 minutes, we're able to do my the transfer approach with EMG triggering around 50 minutes. And then my dressing began placing screw at 52 minutes. I began my disc prep at around an hour after the spinal, and then we finished decompression at around 75 minutes. I placed my cage around 80 minutes, and then we finished around closing around 100 minutes or so, and then the whole wound will close around 2 hours and 18 minutes. So total about 2 hours and 18 minutes total for this case, well below the 3-hour limit of spinal anesthesia. For my workflow for the lateral approach, I typically made a vertical incision about 3 centimeters long. I dissect to the muscle, the abdominal muscles, until I reach retroperitoneal fat to make sure that I'm not in the wrong cavity. And then I use my finger just to gently remove the abdominal content anteriorly. And then I use my navigation probe to go transfer into the disc space. And then I use sequential dilators to open up the psoas and then to get to the disc space, place my retractor, do my discectomy, distraction, and joint cage. So this is kind of my workflow here, and I'll talk more about that in my video later. I learned so in terms of exposure for lateral approaches, some people use the finger to kind of dissect with the finger into the retroperitoneal cavity. I like to visualize the anatomy as I dissect through. So for me, the way I dissect through is that I use these 2 Kelly. This is the one that I typically use on the left side, but sometimes you have bigger patient, and then there are these like very long Kellys that you can use that can allow you to dissect a bigger patient to reach the retroperitoneal cavity. So this video here just show quickly how I do my dissection for my lateral access. So after I place my reference frame into the PSIS, you can see here. Sorry. You can see I get an O-arm spin here. And then after that, actually measure out the entry point for the lateral approach by finding the mid vertebral body. So you can see here, we measure the midpoint of the vertebral body. We draw a line that parallel to that, and I just follow this line as I make my incision and I do my cage. So this is a different case that we're talking about, but you can see how I kind of mark out my incision with the navigation, make sure my incision is in line with the mid vertebral body. I just make a vertical incision, and then I just use my Kelly, just go layer by layer. So you can see here I'm going to the subcutaneous fat, and then I'm cutting down the external oblique fascia here. After that, I just use the Kelly, just to spread it sequentially, layer by layer, to a different muscle. I went to external oblique, internal oblique, transverse abdominis, and then just slowly and slowly, I would reach the retroperitoneal fat. And this is when I begin to dock my probe. And it's important to visualize this fat here because you can see on this video here, see that yellow part here, that's the retroperitoneal fat. And it's important because it makes sure that you're in the right area. So I do this step by step until I see the fat, and then I kind of dock my probe. to get to the disk space. So now I will show some footage from the actual prone lateral, awake prone lateral. So you can see here, this is anesthesia. We have the patient in the OR. He was sitting up, and then we pump at the L3, L4 area, and we just do a spinal tap basically. Use a 25 gauge needle, very small, inject the bupivacaine into the interstitial space, and this allows us to have the spinal anesthesia. So after that, we put him prone in the prone position. As you can see, as I mentioned earlier, I was get his shoulder down a bit lower to accommodate the frozen shoulder. We then prep and get the patient ready. After we have prepped and draped the patient, I place the reference frame here in the left PSIS, and my resident placed the striker screw into the spinal process here for the navigation for the O-arm spin. So after we have done this, we got an O-arm spin. This is about almost half an hour into the case already, but this is just preparation here. So we got an O-arm spin about 27 minutes. And then the first thing I always do is after the spin, I always check to make sure that my navigation is accurate, right? So I use this probe here. We call it the chicken foot. So we put the tip of the probe on top of the striker screw. So you can see here, it's actually very accurate. The tip is right on top of the metallic object here. So confirm that it's accurate. And I do this throughout the case, make sure that your patient has not moved around, the frame did not get moved, nothing changed. So that's a way to confirm that you were accurate throughout the whole operation. So next I will play a video of the surgery. This is narrated by my research fellow, Dr. Quinones. Let me know you cannot hear anything.
The procedure began with posterior exposure using standard subperiosteal dissection. On the lateral side, dissection was continued through the abdominal musculature and transversalis fascia until the retroperitoneal fat was encountered. The schematic with the red arrow and circle illustrates the coordinated handoff and seamless transition of instruments between the surgeons. Following entry into the retroperitoneal space, the retractor arm was secured. To access the L3-4 disc space, a navigated dilator was advanced to the psoas muscle and gently mounted to reach the lateral osteophyte. As the posterior surgeon created a pedicle screw pilotable, the lateral surgeon sequentially advanced dilators for trans-psoas access. Trans-psoas access was guided by directionally triggered EMG monitoring to assess proximity to the lumbar plexus. The posterior surgeon then utilized the navigated pedicle finder, operating in parallel with the lateral surgeon, assessing the trans-psoas corridor. The posterior surgeon then proceeded to tap the pedicle tract, while the lateral surgeon continued sequential dilation using tubes of increasing diameter to fully clear the psoas muscle. As the tap was withdrawn, the lateral retractor was inserted. Simultaneously, the pedicle walls were palpated. The right L3 pedicle screw was placed into the prepared tract, while the lateral surgeon performed the annulotomy using a disc knife. It is important to note that both the L3 screws were placed prior to the distraction of the disc space to minimize navigation inaccuracy. To maintain a consistent and controlled trajectory at the midpoint of the disc space, a reference orange line was drawn on the navigation system, as indicated by the green circle. All disc preparation instruments were advanced along this trajectory. A small navigated Cobb elevator was then introduced into the disc space and gently advanced with malleting, taking care to avoid end plate violation. Once the contralateral annulus was breached, fluoroscopy was utilized to confirm the integrity of the end plates. A larger Cobb elevator was then used. During this step, navigation was briefly disrupted when the posterior surgeon inadvertently rotated the reference frame of this instrument into the camera's field of view, as denoted by the yellow circle. The issue was corrected by repositioning the reference frame out of the optical path, allowing navigation to resume without further interruption. The large Cobb elevator continued to be gently malleted across the disc space to disrupt the contralateral annulus, with meticulous attention to maintaining a controlled trajectory to prevent end plate violation. This consideration is particularly important in the setting of a collapsed disc space. The left L4 pedicle screw was then placed. Notably, all 4 pedicle screws were inserted with the posterior surgeon positioned on the right side of the patient. This minimized unnecessary repositioning and helped preserve workflow efficiency throughout the procedure. 4mm and 6mm distractors were sequentially passed through the disc space to gradually restore disc height and assess end plate mobility in preparation for cage placement. The left lower inset photograph illustrates the view of the disc space prior to insertion of the interbody cage. An 8mm trowel was inserted into the disc space to assess fit, alignment, and restoration of disc height. Fluoroscopy was utilized to confirm proper positioning and trajectory. At this point in the procedure, the posterior surgeon initiated the decompression. A 10mm interbody cage with 6 degrees of lordosis was selected. It was then gently mounted into the disc space under controlled guidance to ensure proper seating and trajectory. As the interbody cage was being mounted into position, the patient reported abdominal discomfort and nausea. The procedure was temporarily paused, and the anesthesia team responded promptly, evaluating the patient under the surgical drape, as indicated by the yellow arrow. Antiemetics were administered, which resulted in the resolution of symptoms. Additional local anesthetic was provided to optimize patient comfort. The procedure then resumed with completion of interbody cage placement.
You can see from this video here, as we're doing the cage, and as you can see, it was a very tight disc space. So as I was modeling, as I was having the cage in, he became very uncomfortable from that. So we just stopped the operation for a few minutes until he got more comfortable, and then we continue. And that was okay.
Posterior decompression was carried out concurrently, allowing both components of the procedure to progress in parallel. Fluoroscopic imaging was obtained in both the AP and lateral projections to confirm cage positioning. Final cage placement was completed at 80 minutes from the time of spinal anesthesia initiation. The fluoroscopic images shown here demonstrate optimal cage positioning with no evidence of end plate violation. After achieving adequate hemostasis, the lateral retractor was carefully withdrawn from the surgical field. Total retractor time was 28 minutes. Posterior decompression continued while the lateral incision was irrigated and closed. Closure of the lateral incision was completed at 107 minutes. The lateral surgeon then assisted with the final portion of the decompression. Following decompression, rods were placed and final tightening of the set screws was performed. Fluoroscopic imaging was then obtained, confirming appropriate positioning of the interbody cage and pedicle screws. Liposomal bupivacaine was administered to provide extended postoperative analgesia. The procedure was completed in 138 minutes.
Yeah, so that's our video footage. Patient did go out of surgery. He stayed in hospital for a couple of days because we placed a JP drain for hemostasis afterwards. It's a post-op CT scan showing good cage placement with an MRI post-op showing good decompression from the back. I saw him last about at 3 months post-op. He's been doing well. So in summary, I think the prone lateral approach is a great surgery in terms of becoming more efficient and trying to get things done quickly. I think the spinal anesthesia is good for patients with severe cardiac history. It offers them another alternative in terms of spinal surgery. And navigation is very important for this workflow. I think it'll be much harder to do this with fluoroscopy. It can be done, but I think it's just not as efficient. So I'll stop here for any question before I move on to the next part.
Hey Stan, that was a absolutely phenomenal presentation that you just gave on this first part. Are you guys planning on publishing that at all? This is the first that I've heard of awake prone lateral surgery. I think you're definitely pushing the envelope big time here.
Yeah,
are you guys planning to publish this?
Yes, Mike. Yeah, we actually got it published in New Surgery Case Lesson
Oh, okay.
about a month ago. Yeah. So hoping to get the video published somewhere too. So
Yeah, you can actually, I don't know if it's too late, but you can actually publish videos with case lessons as well. But this is a phenomenal tutorial. I wanted to ask you a couple of questions. Mike Selby from Australia made a comment that you've got fantastic workflow. He was really impressed with that. Mike does a fair amount of prone laterals as well. One of the questions I have for you is how often you're doing prone lateral surgery for pathology like this. When I looked at the pre-op scan, it's a pretty typical, MRI scan that I think we all see in clinic. I have clinic today. I'm still stuck here. I see many patients with scans like this, and obviously there's a lot of indication for surgery here, but what we all offer patients is vastly different. So I'm just curious, is this kind of like your typical workflow where you'll offer patients prone lateral surgery when they have maybe a degenerative spondylolisthesis with pretty significant lateral recess stenosis, or are there other factors that you're looking at, like they have to have severe foraminal stenosis as well? Like just take us through your thought process for that.
yeah, I think I really like collapsed disc space when they have severe stenosis from the collapsed disc space. This patient, you can see it has been much like no disc left at L3, L4. So I think doing a lateral cage really gives him a very good indirect decompression to open the foramen up. That's kind of my workflow. Anyone with severe foraminal stenosis with collapsed disc space, I think they benefit greatly from a lateral cage. In this guy, I also wanted it posteriorly too because he has very severe stenosis from the back too. That's why we offer that.
Have you just done one prone lateral awake surgery, or have you done many of these at this point?
Yeah, just one so far. When I started out doing this, I started out doing awake discectomy first, and then worked on my way up to some T-leaf and some just screws fusion only, and then this is my first kind of prone lateral awake. So we're hoping to do more in the future as we get more patients.
Have you ever had any issues when you're doing awake surgery, where you've had, patient motion during the operation? Obviously, you're relying very heavily on navigation for a case like this, and one of my concerns would be if patient, God forbid, started waking up, moving around, throws your navigation off. How do you kind of get around that?
Yeah, that fiducial that I placed in the bone in the spinal process, I found that very helpful. So even if they move, I just put my probe on top of the that striker screw, and if it stay accurate, I continue with my case. Sometimes you get an O-arm spin root register, but I haven't had to do that yet because we can make sure that they stay still to the case.
Yeah, that's a great uh, nuance that you integrate into your workflow there that I think I definitely want to do for some of my navigated cases. So I really appreciate you sharing that with us. Um, it doesn't look like we have any other questions at the moment, so I'll let you proceed with the rest of your talk, Stanley. That was fantastic. Thank you.
Yeah, thanks, Mike. So second part of my talk is about using some AI technology in terms of on the research side of this. Um, um, so for pedicle screw right now, we typically look at the endpoint, right? So we place our screw and we see whether or not there's a bridge, and with a post-op scan to determine that, and that's to be done for research purposes, and also for clinical purposes. However, one thing I'm very interested in, I think Mike also has an interest in this too, is looking at videos of people doing surgery and see how we can quantify that, analyze that, and see if we can learn anything from that. So for this project here, what we did was we actually capture migration doing placing pedicle screw into the sawbone model, and kind of analyze the hand motion in real time to see what we can learn from that. So so for this case, I had migration at different level, PHOI 1, 3, and 6, and I had them place pedicle screw freehand and with robot assistant. In this case, the Major robot. And then what we did was we captured the video with our iPhone, and then we used this AI algorithm to detect the hand in real time. So I'll show you a video here. Here's my resident placing a pedicle screw freehand. And so for this, we just capture video. This on the inset here. That's just a normal video that we capture of him doing this, right? And then after we capture the video, we process this with our AI algorithm, and the AI can actually identify the fingers and the joint, on both hands here. There's no special sensor here. Like this is a hand with normal surgical gloves, and you can apply this to any surgical video that you want with this algorithm, and then you can detect the hand motion, how fast the hands are moving, etc., and it can track the hand throughout the frame of the video, both the palm and the back of the hand. So this is him doing a freehand. You can see, and the next video I'll be showing is that him doing this with the Mahjong robot assistance, and you can see that with this also, would you capture the video? I'm sorry. Oops. Here, this video is so doing robotic assisted. So with this, would you capture the video in real time? Then we process the video through our algorithm, and you can see how it's tracking the hand in real time. Sorry, this. After we done this, we can map the coordinate of the hands into a 3D spatial temporal space. So you can see this is kind of the information that we extracted, from the hands, and it show the right hand in red and the left hand in blue. And this is just like a time lapse of the operation, showing what the hands are in space at different time points. And the diameter of the circle here kind of show how fast the hand is moving. So it's a very it's a great way to quantify distance, how much the hand moves in real time, and allows you to kind of quantify surgical hand motion in more details. So by doing this, we come up with a few parameters we can analyze with the video. So you can analyze the distance the hand moved, how fast it's moving, the speed, velocity, acceleration, and jerk. Jerk is just refer to the how much is the acceleration over time. It kind of quantifies how much I guess jerking motion you have with your hand and how steady your hands are. So it's a good way to quantify that. So on this graph, it describes the just the different displacement over time, velocity, acceleration over time. You can quantify all those parameters. Um, and then this is kind of the findings here. So you can see on this graph here we have the PGY 1, 3, and 6, and I mean this is a more sample size, but actually interesting is that the PGY 1, he moved his hand quite a bit compared to the PGY 6, right? So and then the speed of the hand is also much faster than the speed of the hand of the PGY 6. So I think what that means is that even though this is one just a small sample size, I do think that as someone who's become more mature, more experienced, they move the hand less when they do surgery, right? Less motion and more steady hand as you place the screw. So it's an interesting finding. I mean, but we need to replicate that with more sample size. But it's one thing that you can kind of quantify with these technologies here. So after we classify these parameters, it's important to with machine learning and everything to see if we can use the data that we have to kind of classify and predict, what kind of user that we had in the first place. So for this, what we did was we didn't have enough data, so we used what we call synthetic data. So we actually vary the variation of the data at the high deviation or low deviation to get more data for our analysis. And we use different machine learning algorithm to kind of train the data to see if they can predict who the user was in the first place. So by doing this, we're able to come up with a metrics that we can kind of predict. Let's say you give me, this video with this person, I can analyze the video based on the hand motion, tell you, this person is someone who's experienced or who's not experienced, who's early in training or who's later in training. So actually a very kind of powerful approach to analyze people's skill set by using video analysis. So in summary, I think this technology is great to analyze like surgical videos, especially the hand motion. I think it's a way to quantify this objectively with like real data and real measurements. And then you can use this data to kind of predict and classify the level of training or experience. For our future applications, we're hoping to do this on different spine surgery videos, other procedures, and I'm looking for collaboration. So anyone has video of surgeries that they're interested in looking at different parameters, happy to cooperate and work with on this project. So, any question before I move on to the next part?
Yeah, Stanley, this is fantastic. Certainly, I'd be happy to collaborate with you on this. As you know, I do a lot of surgical video education. I publish a fair amount of videos. We show them all the time in our didactics at UNC. Some of my partners are getting into it with peripheral nerve and cerebral vascular as well. It's a little bit harder to capture spine cases, as you know. We have to be pretty creative in the way that we capture that video. What modality are you using to capture video in these situations?
Yeah, I mean, for this one here, I just use an iPhone, but I think you have a dedicated camera. You can capture it. I'm not sure how you do it, Mike, but any video that you capture, we can analyze it, based on the anatomy of the hands or any other parameters you want to look into.
Yeah, I'm wondering if this is in the future going to be a nice way that we can objectify the ways that we evaluate our neurosurgical residents. Right now it's very subjective. We have our biannual review, and I think it's really difficult to objectively give feedback to a resident as to how they're doing. Right? It's just kind of, hey, you need to work on X, Y, and Z. But if we're able to give them some true objective data, I think that would be a lot more useful for them. So I think that there's a lot of application from what you just showed in the last 5 or 10 minutes.
Yeah. I mean, that's our goal too. I think you can have someone like put a barcode screw in and take a video of their hands after they do the case, and you can tell them, you need to work more on this or that. So I think it's very helpful. The last part I'm talking about is using MRI to look at bone health, and there's a I think there was a few talks on this platform about bone health. I mean, there are different ways to look at bone health. The gold standard is DEXA scan. You can also use the CT lumbar spine, look at the house field unit. Another parameter that you can use is the VBQ score, and this is based on the MRI, the lumbar spine. We all have MRI lumbar patient we see in clinic, and can we use that MRI to quantify bone health? And there's a score called the VBQ score, and it's a way to look at bone mineral density, and this is important for spine surgery, as you all know. You smoke or you have poor bone quality, you have a high risk of failure or osteoporosis. So quantified bone health is very important before any kind of big fusion or even small fusion in general. So we wanted to look at the VBQ score on MRI, and then we wanted to find a way we can automatically kind of like have a platform to automate this process, right? Because it takes some time to measure the value and figure out all these things. So we want to develop an algorithm where we can use some AI technology to make that process much faster or smoother. So the way that we look at VBQ or vertebral bone quality score is that you do by hand, right? What you do is you get a T1 MI, a sagittal MI, mid-sagittal typically. You measure the signal intensity of the vertebral body at L1, L2, L3, and L4. And then you also measure the signal intensity at the CSF around behind L3. And this allows you to normalize the signal to CSF. Because sometimes MRI can change, they get it done on different scanner, different Tesla. So it can change. So it's important to normalize that value to the CSF. So you can see here, what we do, we calculate the VBQ, the signal intensity of the bone, the vertebrae at these levels. We find the median value of those values, and we normalize that to CSF. However, doing this can be time consuming, right? And then sometimes, if you have a different person doing it, it can be different from another person doing it. So we want to find a way you can kind of automate this process, make it faster. So my goal was to develop an algorithm to automate this process, and I think this allows us to be done faster and more objective. So for this study that we did, we actually have over 1,000 MRI lumbar spine MRI that we were able to download and use. And then what we did was we have a lot of students helping us with this project, and then they manually, here on this left side here, they manually kind of label every vertebrae L1 to L4 and the CSF as well. And then at the same time, we develop an algorithm that can automatically do this. So you can see on this picture on the right side here, this is on the left side is how a human would do it. Here's on the right side how a computer would do it. So the computer would kind of segment the spine, and it would identify the vertebral body, and then it will place a region of interest into the area that we would be interested in. Then it will sample the CSF signal and then normalize that. So this can be done automatically with our software here that we created. So we did that for 1,000 MRI. We compared manual versus automated quantification, and then we also wanted to figure out whether or not the VBQ score correlate with the DEXA score in terms of bone health. So here's the workflow here. So what we did was we obtained this MRI lumbar spine, the T1 mid-sagittal. We put it into our AI model. And then when you use AI model, the first thing you want to do is go segmentation. So you segment the spine to different parts, right? So in this case, you can see we segment into the sacrum, the L5 is on this space, L5 body, 4-5 this space, and so on. We also segment the thecal sac here, and then the spinous process from behind. So after you segment the spine, you're able to label each vertebrae body. And then the software will then draw like a border around each vertebrae body at L1, 2, 3, and 4. And then we draw a circle into the region of interest. This is done automatically by the software. We sample the CSF and we come up with the VBQ score. So this is definitely much faster than do by hand, especially if you have like hundreds or thousands of MRIs to do. So we coordinate the VBQ manually versus automatically done with the software, and it actually has a very high correlation of 0.86. So so this so that the automatic VBQ that we created can actually can match the manual VBQ pretty well, almost up to 90%. And then the next thing that we did was we're trying to quantify the VBQ score with the DEXA score. So as you can see on the x-axis here, the DEXA score, right? So anything less than 2.5 on the T-score of DEXA is typically considered osteoporosis. And then most studies right now use the VBQ score of 3 as a cutoff point for osteoporosis. So you can see that in this case, you have a high VBQ score that over 3, it almost predict that you have osteoporosis here. We do have some false negative down here. I think it just has to do with the sample size, but we do have very high percentage of true negative. So based on this experience, I found VBQ to have very high specificity, but low sensitivity. And I think that if we lower the threshold, we have more data in the future, we can have a higher sensitivity. But at least for this data set we have very high specificity. So meaning that you have a high VBQ score more than 3, you can say that with very high certainty that this patient has very poor bone health. So I think it's a good marker for osteoporosis. We are having to get a DEXA scan. So in summary, VBQ can be done automatically with an AI algorithm. I think it allows you to analyze large data set and to quantify bone health, quickly using an MRI. And we hope to use get a more bigger collaborate with other people, get a bigger data set, and to create a better algorithm for this pipeline. In the future, we're looking at the bone plate as well. I'm sorry, the end plate as well. I think that's good. That's important for cage placement. So we're working on an algorithm right now to quantify the bone plate quality score, and that's done similarly with the VBQ, but looking at the end plate more than the vertebrate body, and then looking at muscle quality as well in the future. And the more data we have, the more powerful our model will be. So looking for collaboration too for this project. Anyone's interested in this? Yeah, that's my talk. Thank you everyone for listening. These are people that all the students I have been working with. We have Christian here. He's on the call, working very hard this year. He did love this work, so I want to acknowledge him personally. And then we have all these students helping us. So thank you.
Hey Stanley, that was a absolutely fantastic talk. Couple questions, looks like from the chat box. Martin Green had asked, when measuring the kinematic data of hands, is the hand position tracked in relation to the patient practice anatomy taken into account in the X, Y, and Z axis?
Yes, you can set the reference point at anywhere, using the software. So yes, you can set it to any reference point in space.
Okay, I have a couple questions, comments about the last part of your talk. All this work that's being done by you and others in regards to other modalities that can maybe supplement DEXA scans, such as Hounsfield units. One of the issues I think that we're all running into is that even though there may be equivalence to the DEXA scan in relation to there being a high correlation to the T-score with Hounsfield units, maybe less than 140 correlating with osteoporosis, your VBQ score correlations. At what point do you think insurance carriers will start recognizing some of this other data? Because we all run into cases where maybe the DEXA scan might average out to osteopenia, but when we measure the Hounsfield units on a preoperative CAT scan, it's far in the osteoporotic range. Like I had a patient the other day whose DEXA score averaged out to negative 1.3, but her Hounsfield units were averaging out in her thoracic and lumbar spine to about 75, right?
Yeah.
At what point do you think insurance carriers will start realizing this data and maybe acting upon it?
Yeah, I think right now there's no FDA approval for device to look at using these parameters for screen for osteoporosis. So I think if someone can work on some kind of software that can use all these Hounsfield unit, VBQ score, and get FDA approval and showing that it has equivalent accuracy or relevance to the DEXA score, I think that's when they will begin to use that. But I think without FDA approval for any kind of technology like this, I think it'll be hard to get them to use that data. But I know some companies are working on this kind of projects here where they're trying to get the VBQ score calculated automatically, and try to get FDA clearance to use that to screen for osteoporosis.
How time consuming is it in your clinic to calculate this score if you didn't have access to an AI model to assist you?
Yeah, I think I get this call done like maybe 5 minutes, Mike. I think you have the right back system and know how to do this. I think you get done in a few minutes. But I think for like research purposes, having an automatic kind of software to do this, I think is much more powerful.
All right. Well, I think that's about all we have for time, Stanley. That was really fantastic talk that you gave. It's a very forward-thinking talk. This is definitely some topics that have not been brought up before. We've been around for about 4 or 5 years now in virtual global spine, and I think a lot of the topics, kind of resurface again because it's hard to find, new things to talk about when we have talks every single week for the last 5 years, right? This is definitely a very forward-thinking talk, so we genuinely appreciate you contributing to our repository in virtual spine. This is definitely a talk I'm going to encourage others to watch. I'm sure I will watch it again myself. And again, really happy to have you here, Stanley. Thanks so much, and best of luck with everything moving forward.
Yeah, thank you, Mike. It's a great platform, and like I say, I learned so much from this from everyone. So we should continue doing this.
Absolutely. Yep. There's no plans to stop. All right, guys. You have a good rest of the night. Make sure that you check LinkedIn and X to see who's up to give us a lecture next week. Thanks again, Stanley. Have a great night, guys. Bye.
Yeah, thank you, Mike. Bye bye.